diseases of the kidney can occur in any part of the kidney. The diseases that we'll talk about now are diseases that are a result of dysfunction of the tubules or the interstitium of the kidney. We'll start by talking about disorders of tubular function. Now, there's some hereditary diseases that can cause this. One is Fanconi syndrome. Fanconi syndrome is a hereditary or acquired dysfunction of the proximal renal tubules, in addition to some hematologic disorders as well, which we'll talk about in the hematology lectures. Clinically, this manifests as glycosuria. That means glucose or sugars in the urine, hypophosphaturia, hyperphosphatemia, amino acid uria, which results as a defect in absorption of amino acids, and systemic acidosis. Basically, what happens in this disease is you're not able to reabsorb or secrete things from the tubules as you normally would, and that leads to all of these clinical manifestations. That's all you really need to recognize about Fanconi syndrome. You'll learn later in hematology the hematologic manifestations of this disease that come along with it. Cystinuria is a genetic defect specifically in the tubular reabsorption of the amino acid cysteine. So what happens in this disease is that you filter cysteine at the glomerulus, but you fail to reabsorb it in the kidneys. A consequence of that is that you get high concentrations of cysteine in the urine. These high concentrations of cysteine then can lead to formation of cysteine crystals and eventually the formation of cysteine stones, leading to nephrolithiasis or kidney stone diseases. Another type of hereditary tubular dysfunction is Hartnum disease. Again, this is a defect in reabsorption. In Hartnum disease, which you described quite a bit in biochemistry, there's a genetic defect in the reabsorption of many amino acids, but particularly for tryptophan. Remember that tryptophan is important in the formation of niacin and nicotinamide type nucleotides like NADH and NADPH. So what you get in this disease is a pellagra-like syndrome as a result of defective reabsorption of tryptophan. Now, there are also some diseases which affect both the tubules and the interstitial matrix of the kidney. One of these is what we call acute tubular necrosis. This is actually the most common cause of acute renal failure in the United States. This is characterized by destruction of the tubular epithelial cells. Now, the great thing about the tubular epithelial cells is if you can reverse this disease, those tubular epithelial cells will actually regenerate and you can regain some of the renal function that's lost. Clinically, what you see is oliguria, that is decreased urine output. You'll see metabolic acidosis because of defects in the regulation of electrolyte metabolism by the kidneys. You'll see hyperkalemia due to retention of potassium by the tubules of the kidney, and this can lead to cardiac problems and arrhythmias. And you'll also see dirty brown granular casts in the urine itself microscopically. These dirty brown granular casts are actually necrotic tubular cells that have found their way into the urine. Now, acute tubular necrosis is most often caused by renal ischemia, and you see this in like hypotension or shock, where there's a sudden decreased perfusion of the kidney leading to necrosis of those tubular cells. In addition to shock, it can be also precipitated by certain drugs, an overdose of penicillin, sulfonamides, gentamicin, contrast agents, and so on and so forth. Particularly, you'll want to remember ethylene glycol. Acute tubular necrosis is a predominant feature of ethylene glycol poisoning. It's also associated in this case with intratubular oxalate crystal deposition, which you'll see those two things together in ethylene glycol poisoning. Mushroom poisoning, you'll see this as well, and also in crush injuries where necrotic muscle release a lot of myoglobin. This will lead to acute tubular necrosis as well. So this is what it looks like. If you look at this picture, you see a bunch of kidney tubules, and where the arrows are pointing, you'll see that the cells around this tubule have been lost. They're gone, and that's because they've become necrotic, died, and then been released into the urinary system. Now, another type of tubular interstitial disease is what we call acute interstitial nephritis. Now, unlike acute tubular necrosis, which involves the tubules, this is due to inflammation of the interstitial areas of the kidney. Now, this is usually caused by a hypersensitivity reaction, and the patients with AIN present with fever, dysuria, oliguria. They may have a rash, and they'll have peripheral eosinophilia. That means increased eosinophils in their peripheral blood. You can also produce what we call eosinophiluria, which is eosinophils in the urine itself, but this is rare. If you do see it, however, this is pathognomonic for a hypersensitivity AIN. The acute interstitial nephritis is also caused by exposure to drugs, especially sulfonamides, penicillin, thiazide diuretics, and nonsteroidal anti-inflammatory drugs. And the NSAIDs are probably the biggest, most common cause of acute interstitial nephritis. What you see is edema. You see infiltration of the interstitial part of the kidney by inflammatory cells, including monocytes, macrophages, lymphocytes, plasma cells, and eosinophils. If you take away the drug, though, this can resolve and you can get a resolution with some return of renal function. Here's a picture of what it looks like, and this picture is very classic for interstitial nephritis. What you see is an interstitial infiltration of a lot of eosinophils. You see all those eosinophilic cells there. Those are eosinophils that, along with lymphocytes, macrophages, and plasma cells, have infiltrated the interstitium of the kidney. A third type of tubulointerstitial nephritis is what we call urate nephropathy. This is caused by precipitation of uric acid crystals in the renal tubules. You typically see this in two different diseases. One is in people who have leukemia or lymphoma who get chemotherapy. The rapid death of the cells caused by chemotherapy causes a huge increase in uric acid production that we described in the biochemistry lectures. That rapid increase of uric acid leads to precipitation of that uric acid in the kidneys, leading to urate nephropathy. The other place that you can see this are people that have other hyperuricemic diseases, things like Lesch-Nyhan syndrome or hyperuricemia leading to gout. And in this, you see deposition, again, of monosodium urate, or MSU, in the tubulointerstitial area of the kidney. Now, what you see in this, so you can see the deposits by light microscopy, but again, you have to use polarized light. And when you do, you'll see these birefringent needle-like crystals in the tubular lumina or in the interstitial areas of the kidney. Now, another type of tubulointerstitial disease is another deposition disease. In this case, you get diffuse calcium deposition in the parenchyma of the kidney. This is called nephrocalcinosis. Now, this can either be a cause or effect of renal failure. In individuals that have renal failure and develop hypercalcemia as a consequence, may get deposition of calcium in their kidney secondarily. Or it can actually be due to hyperphosphatemia, which comes from other causes. So you can get hyperphosphatemia or hypercalcemia leading into calcium deposits, and that causes renal failure. Now, remember that there are a lot of causes of hypercalcemia, but some examples are hyperparathyroidism, excess vitamin D, sarcoidosis, milk alkali syndrome, squamous cell carcinoma, metastatic diseases, and so on and so forth. A particular cause of tubulointerstitial diseases is multiple myeloma or plasma cell myeloma. Now, remember, in plasma cell myeloma, you have excess production of immunoglobulins from neoplastic plasma cells. Now, the light chains that are produced by these plasma cells are called Bence-Jones proteins, and they tend to get released in the urine and deposit in the kidneys. When they deposit in the kidneys, they're toxic to the epithelial cells and can cause tubulointerstitial nephritis. In addition, they can combine with what we call Tam-Horsfall proteins, which are also immunoglobulins, to form casts, which you can detect in the urine. Another thing that happens in plasma cell disorders is that these light chains can aggregate together to form amyloidosis. Those amyloid deposits can form in the kidneys and lead to kidney diseases. In addition, multiple myeloma causes lytic bone lesions, which lead to hypercalcemia and can cause calcinosis or deposit of calcium in the kidney. All of these things can combine to cause tubulointerstitial diseases and dysfunction of the kidney in plasma cell myeloma. So this ends the section on tubular and interstitial diseases.